Hello, everyone. On behalf of the MIT South Asian Alumni Association, welcome to the webinar. I'm Monica Sircar, and I will be moderating today. The MIT South Asian Alumni Association has over 3,000 MIT graduates of South Asian descent from Bangladesh, Bhutan, India, Nepal, Pakistan, and Sri Lanka. Our history is a fairly long one. The first student from South Asia graduated from MIT in 1882. Currently, the MIT South Asian Alumni Association and MIT India, along with Professor Iyer from the MIT History Department, are working on archiving our history. Our project tells the remarkable story of South Asia at MIT and MIT in South Asia. It highlights the determination and grit of multiple generations of South Asians at MIT. We celebrate the far-reaching accomplishments, technical expertise, and ingenuity that have made significant contributions to the advancement of knowledge at MIT and life beyond the Institute, South Asia, the United States, and across the world. We are also planning an exhibition in the fall of 2022. Please visit our website, mitsaaa.alumgroup.mit.edu, to learn more about the project. If you know of an alum who is not on our email list and would like to be on it, please encourage them to join us via Facebook, Instagram, or LinkedIn. Our webinar series have been very popular and is a centerpiece of our outreach program, spearheaded by our wonderful president, Dr. Ranu Bopanna. Attendees at our webinars are from the larger MIT community. The last MITSAAA webinar was on heart diseases, where cardiologists from India and the United States made joint presentations and participated in discussions. Today's webinar is on a relevant topic, the COVID Delta variant. We have been exposed to, actually bombarded with, enormous amounts of information, sometimes confusing, sometimes contradictory. We're honored to have two distinguished speakers who are experts in COVID management and treatment modalities. We have Dr. Sujit Suchindran, Assistant Professor of Medicine at Emory University, School of Medicine, Atlanta, Georgia. He is a practicing infectious disease physician. He graduated from the University of North Carolina Medical School at Chapel Hill, where he also completed a master's in public health. Afterwards, he completed residency training in internal medicine at Duke University Medical Center in Durham, North Carolina, followed by infectious disease fellowship training at Massachusetts General Hospital and Brigham Women's Hospital in Boston, Massachusetts. After practicing in the Boston area for some time, in 2019, he joined Emory. Our other speaker of the day is Dr. Payal Patel. Dr. Patel is an assistant professor in the Division of Infectious Diseases at University of Michigan, Ann Arbor, and medical director of antimicrobial stewardship at the VA Ann Arbor Healthcare System. She is the current chair of the ID Week SHIA Best Practices in Antimicrobial Stewardship workshop. She is a sought-after medical correspondent for the media, including BBC, NBC, and CBS. Here are some ground rules. Each of our COVID experts will speak for 7 to 10 minutes, sharing their perspectives on the pandemic. This will be followed by questions from the audience and also questions that have been submitted online. Without further ado, let's get started. I'm going to give the floor to Dr. Suchindran now. Please welcome him.
Thank you so much, Dr. Sircar. Again, I'm Dr. Sujit Suchindran, and I'd really like to, first of all, extend my thanks to Dr. Sircar, to Dr. Bopanna and MITSAAA for inviting us here to speak with you today. It's really a pleasure to be with this group of folks. I have to say that although I personally don't have a direct connection to MIT, I consider myself in some ways an honorary member because during my 8 years of living in Cambridge as a Canterbridgian, almost every day I ran by the quad along the Mass Ave Bridge and I always enjoyed the wonderful views of the city from your side of the river. So in some ways, maybe you can consider me an honorary MITer. I wanted to focus my first few minutes on really giving you kind of a bigger picture of my perspective as an infectious disease physician and hospital epidemiologist before Dr. Patel and I delve into some of the details and have a discussion specifically about the Delta variant. You know, I really wanted to give you a background into kind of my role as an ID physician and hospital epidemiologist. And I came into this role as an ID physician when I decided to pursue this career, really appreciating that infectious diseases were the one field of medicine where you really where what you do with one patient in front of you affects so many others around you, and you really have to think from a larger and societal perspective and really have an understanding for politics and economics. And I think that that was really what really brought me into the field of infectious diseases was the infection of HIV. And I never would have imagined that some of those same issues that we deal with in HIV have been crystallized in so many different ways with the current COVID pandemic. As Dr. Sircar mentioned, I'm a practicing healthcare epidemiologist. I'm the hospital epidemiologist at two hospitals in the Emory healthcare system in the Atlanta metro area. So some brief background, you may ask, well, what is actually a hospital epidemiologist? I view my fundamental role as really working to prevent the transmission of healthcare associated infections, both for patients and for healthcare workers. I work very closely with infection preventionists. And for those of you who don't know who an infection preventionist is, they're really the unsung heroes of the hospital, working behind the scenes on policy, practice to keep all of our patients and healthcare workers safe. So in working with our infection prevention team, part of our job has always been to be prepared for events like a pandemic. We even in 2019 and earlier, I remember doing drills and tabletop exercises to work on, think about how our institutions would respond to a flu pandemic or, for example, Ebola. I'm fortunate to work at an institution at Emory University where we have a world-renowned serious communicable disease unit, the SCDU, where we actually treated a number of the Ebola patients who were brought to the United States. So despite working in this kind of milieu of infection prevention, hospital epidemiologist with the world-renowned SCDU, I have to say, even many of us were caught by surprise by how profound and far-reaching the effects of the COVID-19 pandemic have been. Over the first few minutes of just my introductory remarks, I really wanted to kind of just share kind of three major points that I've learned or really been experiencing over the past year. From the beginning when it was really so chaotic, and now, even though many of our policies and procedures have been in place, some of the lessons I still learned and I think are relevant right now. The first is really for me and so many of the leaders that I work with is to be nimble. The data and the science has just moved so quickly, and it's very difficult for us to keep up. And so using sort of best practices from the CDC, and as Dr. Patel will highlight, the COVID-19 real-time learning network, which has been an important resource from the Infectious Disease Society of America, our main specialty organization, really to kind of use to the best of our ability to keep up with what is important and what's relevant, and really be able to communicate that best in a targeted way and be very transparent with our knowledge. I think about in the spring of 2000 when it seemingly new clinical trials were coming out every single day about different therapeutics like antivirals like remdesivir or hydroxychloroquine or plaquenil and steroids. And we had to adopt those so quickly and really communicate from a top-down mechanism very quickly and change the practices that we were doing in the hospital. And I think I learned a lot of lessons about really being transparent with what we know and what we don't know, and really having to admit that you don't know certain things, and perhaps the importance of the ability to say that you may have been wrong in emphasis at some point. I think about some of our initial discussions about the mode of transmission, about a droplet versus aerosolizing form of transmission. And we had to realize that some of our emphasis may have been incorrect in the beginning and really had to be nimble, move forward, and express that communication in the best way we can. I think one of the second things I've learned over the last 20 months has been that expertise matters. I know that I'm an infectious disease physician and I have expertise in the clinical diagnosis and management of infectious diseases, including COVID, but I'm not an expert on all things COVID related. And in the hospital setting, I've learned that there are other people with very relevant expertise. I look, for example, to the expertise of our facilities and engineering team who really understand things like the way the hospital is constructed, the airflow, how rooms are constructed to improve or mitigate the transmission of airborne infections. And so I have to work very closely with teams like that with expertise. I think in a similar way of my colleagues in laboratory medicine who really have nuanced understanding of the different types of COVID testing and how they may relate to how that influences our practice for the patients that we see every day. But I think that the way that this is really relevant sort of in the current day is that, expertise matters now as much more than ever. And I look to sort of more broadly when I see a lot of the misinformation that we have on social media and news platforms. And I really think that, I still look to those people who have specific expertise. For example, aerosol engineers, one who I follow very closely, Lindsay Marr, really an expert in understanding the transmission of aerosol and airborne infections. Immunologists and behavioral scientists, their role is critically important, and their specific expertise is critically important for us to synthesize together. And it's important that we continue to value the expertise of people like that, as opposed to some of the, your aunt on Facebook, or some of the armchair experts that we see sometimes that are promoted on media channels. The third thing that I think is sort of my takeaway that I've learned in my 20 months has been that leadership also really matters. And I've seen leadership at so many different levels, both failures and successes. And I think that the leaders really successfully take, the expertise that they've worked with, and really and be nimble with their communications and data, and really provide that direct leadership to people. And in the healthcare setting, I've seen that in different ways. I think about the CEO of our healthcare system, who recently mandated that all healthcare workers in our healthcare system have COVID-19 vaccination. And in many ways, that was a controversial decision, but I think fundamentally the right one for our organization, and is supported by so many of the of healthcare organizations in the United States. I also see leadership in smaller ways, where I see unit leaders in a hospital, some of whom may have been maybe reluctant to get a vaccine. And I think about how that influences the behavior of the healthcare workers or in a nursing unit who are underneath them. So, and I think one of the examples where I saw that the most was where one of the CEOs of one of the hospitals I work with really put herself in the line of fire and met with a lot of a group of healthcare workers who were opposed to vaccination, and really met with them on their level, spoke to them directly to try to address their concerns. So I think that that's another major thing that I've learned in my experience over the past 20 months. I think all of those three messages, that the importance of being nimble and really being able to respond to new data and literature, the importance of expertise and the importance of leadership, have really been crystallized in my experience in the past 6 months through the vaccination, and the experience that I've had working with my organization and trying to get our healthcare workers and our patients vaccinated. Let me be clear, from in the ID community and the medical community, there's no debate or controversy around vaccination, and we're all wholeheartedly support this and really view it as the light at the end of the tunnel. I think the optimism that I had in December 2020 about the vaccination has waned somewhat because of the steady stream of I think misinformation and challenges that we've had to face. But I fundamentally do believe that the challenges that we're facing, whether from the Delta variant or others, really I look to vaccination as our way out of it. I just wanted to share one last coda before I turn it over to Dr. Patel, and share with you that actually last week, I myself was diagnosed with COVID. And it was a kind of an unusual circumstance, in that I believe that, well, perhaps not unusual anymore, that I think I got it from I was exposed through my children who were in elementary school. But my experience with having infection really emphasizes to me more than anything else the profound power of vaccination. That I had mild symptoms, which went away after 2 days, and I feel well, and I'm participating in this webinar today. So I just wanted to end on that note and share with you my own personal experience with vaccination and infection. And with that, I'd like to turn it over to Dr. Patel.
Thank you so much. Yeah, that was great. I gave a recent talk, and some of the life lessons that I really emphasized were very similar to what you just said. And I think so many of us have realized how important it is to be flexible and stay up to date on information. We've seen that with how the virus was transmitted, with asymptomatic versus symptomatic transmission. And then more recently, we, felt like a little bit like the dish has been flipped with the way that Delta variant has continued to cause, so many crises for us. So I think that that is a really important lesson. I will build upon kind of the things that you talked about by just adding, thinking about this last year, what are some good things, that we've learned or that we have seen come through. And I think about how quickly in our nation we were able to use the federal government and public-private partnerships to get new diagnostics, so new testing for COVID, new therapeutics, so new medications for COVID-19, as well as the vaccine so quickly. And something that both Dr. Suchindran and I are really passionate about we are really worried about antimicrobial resistance. We know that that's been a huge issue worldwide, and we're very worried that we're going to be running out of antibiotics. In fact, we already are. So how can we take the lessons that were learned in this pandemic and use those in other public health emergencies that are going on right now? That's something that I think hopefully will be a positive takeaway. And then the other thing that I just wanted to add is, it's so important to stay up to date. And so I'm going to show at the end of this talk a resource, but in case you can't stay until then, I will just mention that I'm one of the associate editors for a website called the CDC IDSA Real-Time Learning Network. And that is a very trusted resource that is backed by both the CDC as well as our professional organization, which is the Infectious Diseases Society of America, with up-to-date literature on everything that you want to know about COVID-19, whether it's masking, back-to-school safety, whether it's frequently asked questions about vaccines and boosters. That is going to have kind of all of your questions that we may not get to during this hour. And I'm going to, if you want to Google that right now, you can, and I'll share the website later on in this talk. But I think other than that, I think we can probably get started with some questions and answers. And I really appreciated listening to you and hearing your experience.
Thank you both for you sharing your thoughts. I would like to proceed with the Q&A session with some of the submitted questions. The first I would direct to Dr. Suchindran. This question is regarding children and COVID, and clearly very apt given that your recent infection. The question posed from our audience was, how should we prepare our kids going back to school, and what steps can we take to keep them safe?
Yeah, that's great, and certainly so timely right now, with the return to school that's happening throughout the country. I think that during the pandemic, there's been a lot of focus on adults, with the thought that children are at somewhat lower risk. I think that we're seeing the tables turn on that now, and that we're seeing a lot more disease transmission among children, lots of higher kind of numbers throughout the country, and particularly here where I am in the Southeast. And even if only a small percentage of those children have severe effects, when there's so many children who are exposed or infected with COVID, that does lead to significant morbidity and even mortality among children. So I think that we do a disservice if we discount the importance of the burden of disease among children, as well as the outward consequences that is associated with children having infection. I can tell you from my personal experience, I was infected in that way. But I think about children who go home to immunosuppressed parents or elderly grandparents who may have even had that full vaccination. And I think it's important to realize that we can't really get control of the pandemic without having disease control among children. So, with that said, I want to again highlight some of the work that Dr. Patel has done with the Real-Time Learning Network and some of the collaborations she's done with CDC, really outlining kind of what a safe back to school plan is. And I think, like so many of the interventions that we've talked about throughout the country, they're all layered interventions. There's not one thing that will protect children and children's families. There's so many things that when taken together, when taken to really all put together, decrease the likelihood of transmission. I think some of the that are most important are vaccination, and that's vaccination of children if they are eligible, 12 years or above, based on Pfizer's emergency use authorization, or all members of the household who have children, to really stop or really decrease the spread to children as much as possible. I think clearly that's one of the most important take-home messages. Very important is obviously masking, and I really lament that the politicization of masking that has taken place in this country. I think that masks are evidence proven in many ways, and although we are seeking more evidence in children, given a lot of the mechanistic evidence we have, real world and experimental, I do think that there's a clear role for students who can safely be masked to do so in school. A third part of the layered intervention is really improving a school's ventilation and the structural the structure behind the school, to make sure that the school has done everything it can to encourage social distancing, to improve its ventilation, to improve the airflow, to use open windows when feasible. And those are questions I would ask parents to ask of the school and the school system, the school principal, the superintendent. What have you done, to change or improve the school facilities using HEPA filters or however? And I think a fourth part of the layered intervention is testing, and especially in areas of high transmission, doing routine testing, oftentimes with a rapid or antigen-based test, in a systematic basis for children. We know that children can have milder symptoms, maybe atypical symptoms, and then we know that a lot of infection can be transmitted even when people have no symptoms. So I think that routine testing is another part of layered interventions for schools. I turned over to Dr. Patel as well. I know I've taken up a lot of time on this, but I know you've done a lot of work and writing on this particular topic.
No, I totally agree. I think just the way you described it, it's what we want is for the vaccination to be available and uptaken by children as quickly as possible. That will be the quickest way to make schools safe again. But until we get there, we know from this last year, the things that worked were, just like we explained, the masking, improved ventilation, testing. And I would say one statistic that I was struck by this week is, a lot of people have been asking about when the vaccination will come out. And I'm sure this is a question on many people's minds today, when the vaccinations will come out for children under 12. And our hope is that it's going to be this fall. That's what we've heard, because current trials have been ongoing in those younger populations for dosing. But what struck me is that only 15 to 20% of children between the ages of 12 and 18 have actually been fully vaccinated, right? And so that's been available now for months. And there's still so many teenagers that are going to school, participating in sports, that are unvaccinated. In fact, a huge majority. So I'd say if you're listening to this and you have a teenager in your family, your nephew, your niece, your cousin, talk to them. I find that teenagers are actually, very up to date. They want to know, they want to talk about it. And maybe having that conversation could really help. And I think until we get the vaccine for 12 and under, we really need to focus efforts on this unvaccinated group of youth that are going back to school.
Thank you. That's very helpful, both of you. The next set of questions is regarding boosters, and our audience would like to know, can you review the latest information regarding booster doses for vaccines in immune-competent people, and do you envision needing yearly boosters?
I can start it off. So, I think that this is a question again on everyone's mind. I know that we get this question from our uncles and aunts and parents and, on our WhatsApp and text every day. And the reason that we don't have a definitive answer is because if you think about when the first people got vaccinated, right, that was just, 6 to 8 months ago. And so we are now just now learning what's happening to that waning immunity. And that first group of people that got vaccinated was often healthcare workers. So that's a group that's being studied, that's currently being studied. More and more studies are coming out. We have some data from Israel, some emerging data from the US, but it's so early in understanding what all of that data means and what does it really mean for waning immunity. So we know that Dr. Suchindran he actually got a new case of COVID, but he wasn't that sick, right? And so what is that booster supposed to do? Is it supposed to completely stop him from having a case of the sniffles, or is it supposed to stop him from going to the hospital? And he didn't go to the hospital. So again, there's a lot of different definitions, and that's what we're trying to understand. I would say right now, we knew from a few months ago and probably before that people with immunocompromised systems probably won't get as much help with the vaccine and probably need this third shot. And I would almost think of it, rather than a booster, as a part of that primary vaccine series to really get their immune system going. So if there's someone in your family who maybe got a message from their doctor that, yeah, you fall into that category that you need to go get that third shot, totally makes sense. A lot of people, I think, are asking, should I go ahead and just get a third shot before the guidance comes out from the CDC? What we would say from the infectious disease community is just wait and see what the official guidance is, because there's a lot of decisions being made behind the scenes as to whether who is going to need it and when.
Thank you. And what do we know about the possible long-term side effects of these vaccines? I'm sure this has come up multiple times in your conversations.
Yeah, I can start there. Definitely one of the most common questions that I get from, patients that I speak to, healthcare workers that I speak to, a perceived concern about the development of the vaccines and their availability for sort of a year now, and what that means in the longer term. I think that I can unequivocally say that, based on the mountains of data that we have initially from the clinical trials involving around 70 or 80,000 people, but now from the over 250 million doses given in the United States and literally billions worldwide, that the vaccines are safe, and that there really is no evidence of any long-term consequence or long-term side effects, which is actually true for all vaccines, actually, because when you think about the mechanism of action of a vaccination, it provides a short-term instruction, and does induce your immune system to make that protective response. And the side effects that are experienced happen in the short term, in days to weeks. And any of the concerning any side effects that have been found, even the low risk events such as has been found with the J&J vaccine, happen in the short term. And so there really is no expectation that there are any long-term side effects. And now the data that we've had from the trials of following people for over a year, no significant concern. So I feel very reassured about the long-term safety data. I think that, one thing that I've certainly in my experience had to deal with is, I think, the constant swirl of misinformation and how that sort of really kind of mixes into this question of long-term side effects. I've heard many people talk about effects on fertility in the long term, safety for a fetus, the effect of vaccination on their other comorbid medical conditions in the long term. And really, there's no data in any way to suggest any of that. And it's a difficult message to overcome. But when you look at the data, which is transparent, there are no long-term side effects, nor do I have any anticipate that there will be any.
And do fully vaccinated people who suffer from breakthrough infection have any of the long-term COVID problems?
That's a great question. Actually, Dr. Patel?
Yeah, I mean, this is a great question. This is something that's being studied right now. And we don't know the final answer to this. There's some early studies about this. And again, I would say to the MIT audience, who I know is going to read each paper, and you guys are the ones that are going to read the methods and understand it much more than us. I would say the biggest thing is understanding how a paper necessarily defines, right, those post-COVID complications, because if you're defining it for, let's say, 15 or to 30 days after versus a year after, that's already in the future. We're not there yet. And so I think that we actually have a section in our COVID-19 real-time learning network pulling together the data that's coming through on this, but it's almost too early to truly have a good answer to that. And the few studies that have been done, I would really pay attention to the definition of what that is defined as.
Yeah, I can't stress that enough. Those definitions are so important. And, Dr. Patel, you even highlighted earlier sort of that a lot of these studies, the outcome, the definition may be symptomatic infection or severe infection, or sometimes the outcome is actually just having detectable virus, or in a nasopharyngeal swab, or asymptomatic infection. So it's really important when you read the news, read those studies, look at what are they presenting as the outcome, because like you said, those outcomes and those definitions are critically important. It's much more important that we're preventing severe disease than an asymptomatic infection or a mild infection like the one I had.
Very, very helpful. One couple of specific questions that were addressed. If someone has been given non-mRNA based vaccines, would you recommend the person get an mRNA based booster shot?
I think, a great question coming up a lot with the patients in the US who have received, especially the J&J vaccine. I think right now there's still a lot of investigation into this question, and we're looking at what would be, for example, the role of a second dose of J&J or a mix and match strategy. But all of that is still ongoing, and there isn't necessarily a formal recommendation at this time. CDC actually, has explicitly stated that they are looking at this question right now, and they understood that a lot of the discussion about booster shots have left out this population. So I think until we have that data, I would say, hold off. Let's see, whether it's needed or not. But just to stress, whether the mRNA or the J&J vaccines, they've continued to show durable protection in preventing some of the really more severe consequences like hospitalization. And I do know this is a question that about non-mRNA vaccines. It's relevant for the South Asian audience, given the non-mRNA vaccines that are given in South Asia.
Exactly. A couple of interesting questions. What is the difference between the immunity from a previous COVID infection and the vaccine induced immunity?
Yeah, there have actually been studies on this question. And, we had theorized before these studies came out that you would have a more robust immunity with vaccination. And it does seem to be the case. And so what that means is you would have a longer time protected against new infection. Your body is able to build up a stronger defense from the vaccine rather than just having the COVID infection. And then again, thinking about all the sequelae of having infection. And so I know in my practice, I have a lot of patients and actually, often coworkers, not necessarily doctors, but other healthcare workers who thought, I think I had COVID really early on. I'm not sure if I'm going to get vaccinated. And I highly recommend to my own patients, even if you had a documented COVID case, I want you to go to the lobby right now and go get your vaccine, because I don't want you having to come back sooner with another bad case of infection when you could stay out of the hospital and not have to kind of go through that again. So my recommendation, I think the infectious disease community recommendation is definitely to get vaccinated. And the reason is, again, because it does give a more robust immunity. It seems to protect longer.
Very helpful. And do we have any kind of stratification of who tends to get these breakthrough infections? Are they immunocompromised, vulnerable healthcare workers, the elderly, just to kind of reassure those who are curious?
Yeah, I can start.
Yeah, go ahead, Sujit.
Yeah, I'll just start with kind of the experience that we had in Emory Healthcare, where we did an accounting looking at our hospitals about who was admitted to the hospital, and by the vaccination status. And around 90% of the patients admitted in this current surge to our hospital since July have been unvaccinated. So then we took a closer look at who was fully vaccinated and admitted to the hospital. And many of them were immunocompromised, solid organ transplant, chemotherapy, multiple myeloma, or on immunosuppressing medications for other autoimmune conditions. So, I think it's very clear that the people at greatest risk for those severe post-vaccination infections are those who are immunocompromised. Interestingly, we see a number of other different cases too, because all patients who are admitted to the hospital are tested for COVID. And sometimes the people who vaccinated are actually admitted for completely different reasons. For example, someone who came in with a hip fracture, but was incidentally found to have COVID. And really the way I take that is that they were fully vaccinated, they were protected, they had no symptoms, and we found them incidentally as they were admitted to the hospital. So I think that my takeaway is that the vast majority, the vaccinations continue to show robust protection. And I really worry the most about those immunocompromised people who are at greatest risk for having severe infection despite full vaccination.
Yeah, I totally agree with that. And I would say, if you were to look at the literature, there's often studies done on healthcare workers, partly because we're like a really easy population, right? We come to work every day. We we're here in the hospital where people have COVID. And if you tell us like, okay, we're going to stick this, swab up your nose, like just do it, we're going to do it. Right. And so that's often a really often studied population. But again, like looking at that population and whether they had breakthrough infection. So if everyone at my hospital had a nasal swab, but none of us are symptomatic, if that is considered a breakthrough infection, that's really different than the group of people that were actually admitted to the hospital at Emory. And so again, as you hear about some of those things on the news, or maybe you hear about a study, remembering that breakthrough infections themselves have a very wide definition. And so that's, again, how we're thinking about boosters. Do we need boosters in a group of people who, and when do we give them to a group of people who may not have as severe of infection versus people who could get really, really sick and have to get admitted?
And if you ever need to do a study, do it on healthcare workers, because we're willing to have swabs stuck up our nose every week. Yeah.
And one kind of follow-up, can you comment on the Israeli study? Do you believe the waning immunity to this vaccine and kind of an overlay Delta variant, Lambda variant, C1.2, kind of where do you see kind of that confluence of information informing us?
I could start, but I'd be very curious to hear Dr. Patel's opinions on this as well. There's a lot of data out there, and it's important that we, continue to follow that, whether it's coming from Israel, looking at the experience of Iceland, looking at our healthcare workers in the US. And I think it's important that we, look at the data that is coming from Israel. As Dr. Patel explained earlier, the people that were vaccinated earliest in the pandemic were healthcare workers, and in Israel, the oldest of their population. So those are the people that were vaccinated at that time, in December and January. And with Israel experiencing some resurgence of infection, they're looking at who is that, and they are seeing some proportion of breakthrough infections. But it's hard to really tease out whether it's the elderly who are most likely to have some of that waning immunity versus an actual waning immunity issue with the vaccines themselves. I continue to think that the vaccines have shown robust protection against severe infection, hospitalization. But I do think that we need to look at this data more closely. But I do think that one other point I wanted to make is looking at Israel's data. When you look at the case proportions in vaccinated versus unvaccinated, still the proportion of hospitalization and severe infection is much higher among unvaccinated in Israel.
Yeah, I totally agree with that. And I would say, most people listening to this have a science background, engineering background. And so, reproducibility and often a drawback in some of these studies is you did it just in your region or just in your one place. So I think that this Israeli study is really important because it brought the attention to this idea. And now we have to see whether the same thing is happening in the US internationally, and trying to understand whether there's some unique circumstances that could be, unique to the location where it was done. If this was, again, reproduced in a number of different places, that would also kind of change how we were thinking about it.
This is obviously an important medical and scientific question, but part of me also gets frustrated at the attention given to this issue when there are such a high proportion of low and middle income countries where the populations are unvaccinated, where we have such a high proportion in the United States which are unvaccinated. So I do think that these issues are important about waning immunity, the need for boosters, but I really think that the eye on the prize should be getting vaccines to everyone who's unvaccinated. The bottom line message is, in order to get the control of the pandemic, I don't think it's going to be about giving that third, booster to the elderly. I think it's about getting, all the unvaccinated folks vaccinated, and definitely sort of a relevant issue as I talk to my relatives in South Asia, especially.
Excellent. And one question that I want to make sure that we address today is this question that was posed. Is there evidence to support vaccine mandates for public organizations like local government agencies, as well as private organizations and companies?
Yeah, I mean, there definitely is in public health, right? Just looking at the last several hundred years of public health and vaccination. One thing that struck me, I work at the VA, and when we were thinking about the organization was thinking about mandating vaccines, it was initially thought to be controversial, but then when you talk to my patients who are veterans, they often say, the day they enter the military, boom, 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 they get like 15 shots, right? And that's normal. You're entering the military, that you don't want to have something contagious take out a whole unit of people that are living near each other. That has been the way that it has been for hundreds of years. And so we have a new infectious disease. We have a very efficient vaccine. It's more the politicization that has made the word mandate very, I think, controversial, but it's nothing new to the public health artillery. And I will say, just in our personal experience, we've seen, you would be surprised at how many people were maybe not sure when they were going to get the vaccine, and having your employer say, you're absolutely going to have to get this by this date is the thing that pushes them over. And so, especially in America, I do think for that group of people who are not sure, when they were going to get it, a mandate from your employer really can help. Or perhaps a mandate to go to your favorite concert that you want to go to, or to go to that restaurant. Those things, those things are going to push people over. And we were, I was a little bit surprised at how early our professional organizations, including the Society of Healthcare Epidemiology of America and the Infectious Diseases Society of America, did, really formally back employer mandates, because we do believe that is going to be the way to get a group of people vaccinated so that we can really affect the pandemic in a positive way in this country.
Yeah, and I would just add, I think the experience of children also adds to the data and kind of the real world experience with mandates. I look at vaccination requirements on entry to schools, and for example, you look at the MMR vaccine, or measles, mumps, and rubella, and you look at the experience of measles in this country. Measles in the 20th century was a significant infectious disease, causing profound morbidity and mortality with significant consequences for children. After the advent of the MMR vaccine and requirements that school-age children and really children get vaccinated, we saw levels of measles and transmission fall to really tiny levels. But then, kind of before the COVID pandemic, as we were already starting to experience some of the kind of strains of vaccine hesitancy with lower rates of MMR vaccination, we were already seeing sort of breakthrough outbreaks of measles take place in certain pockets of the country. And so I think that we've clearly had experience with mandates which have shown to protect children, protect public health at large, and I think will be one of the most valuable tools as we combat COVID.
And given how grateful we are for the vaccines, one line of questions is that both Sinovac, Pfizer, Moderna were all developed early on before the Delta variant was the predominant strain. How are we working on getting something specific for the Delta variant, or if next it's another variant that's more dominant? How are we adjusting to this new reality?
Yeah, I mean, I think that's a good question. So the what I can say is reassuring to the person who asked that question, and that is that the vaccines still do work. They worked against the original virus, they work against the variants. And actually, we know that, just the information that we have coming back, even the example that we have of Dr. Suchindran getting sick, he almost certainly got sick from the Delta variant. I haven't seen the results, right? But we know how contagious the Delta variant is. And so we know that most new cases of COVID-19 in the US, Canada, almost all countries at this point are Delta variant. And so the vaccines are doing what they were intended to do, and that is to reduce hospitalization and death. So I would feel reassured about that. The question now is, like, what is going to, and we don't have the answer to that, but how is the Delta variant, the Lambda variant, all of these variants going to change the future in terms of what is going to happen with the pandemic? We don't know, and we're, waiting on our laurels to see what's happening too. But I would still feel confident that even those earlier vaccines have been shown to be effective against the Delta variant, and that is really good news.
Excellent. And just to kind of make sure we tick off some more of these, does Delta variant spread outdoors more easily than other variants? Do masks need to be worn outdoors among the vaccinated?
Yeah, great question.
Yeah, do you want to talk about this?
Sure. Clearly Delta is more transmissible than the Alpha, which originally was found in the UK, or the original strains. We often talk in our field about the R naught, which you may be familiar with. Basically, it's the number, so on average, how many people one sick person infects. So the R naught for the original strain was thought to be somewhere between 2 and 3. So one person on average infects 2 to 3 other people. There's quite a degree of variability in that when you think about super spreading events and such, but on average 2 to 3 with the original strain. But Delta, that R naught is thought to be somewhere between 5 and 6. So when one person is infecting 5 to 6 other people, the chance of exponential meteoric rise in the number of cases is just so much greater. That's what we've seen in the US, in India, in the UK, and so many other countries in the world. So, to the person's question, I think it's important to realize that whenever you're in a setting of, close proximity to others, there is a risk. Outdoors in general is certainly safer than a crowded indoor setting where there is poor air circulation and poor ventilation. What I would say is that if you're going to an outdoor event in an area of high transmission, which is literally the entire United States at the current time, but if you're in a setting where, you're probably around to be other unvaccinated people, really kind of getting close to them, especially in an area where people are eating and drinking, I think it would be reasonable to continue. And in fact, I would recommend continuing to mask, just because of how transmissible the Delta variant is. But I do want to emphasize that clearly in the indoor setting among unvaccinated people is where we see, the greatest extent of transmission.
Yeah, I totally agree. I will just say that we have seen more, like initially in the pandemic, one of my favorite journals to read is CDC MMWR, which, they sometimes have some cool articles. And initially it was like, oh, choir practice leads to outbreak, and spinning class, of course, right? Because you're breathing heavily. That led to an outbreak in a spinning studio. And now, as the Delta variant has taken over and more people are vaccinated, we're seeing outdoor wedding, leads to an outbreak, or outdoor motorcycle rally leads to an outbreak. Most recently, there was an outdoor religious camp where many people were unvaccinated, vaccinated. And so I think that just shows that, initially it was case reportable or publishable that, it was transmitting so easily indoors. And we were surprised by that. And that then we knew that was happening, right? We expected that. We weren't shocked by choir practice or spin class anymore, but now we're surprised to see that it's still happening outdoors. And so I just totally agreeing with Dr. Suchindran's advice. If you're going to be at an outdoor music festival, you don't have to stop going to these things if you're fully vaccinated. But let's say if you're immunocompromised, or someone in your family is immunocompromised, or you just don't want to get COVID, it would make sense to have an outdoor mask, especially with what we're seeing reported.
And you may have just addressed this, but this got the most likes as a question, so I'm going to offer it to you. How concerned should we be about indoor dining with the Delta variant? Is it reasonable for short durations, say eating lunch in a shared office with a couple of others separated by 6 feet, or should we really be avoiding all indoor dining?
I think our general advice, and I think especially from the hospital epidemiology community, because Dr. Suchindran actually sees, unfortunately, in his hospital, and we see this at all hospitals in the US, most of the hospital employees that perhaps had COVID, this was happening especially when people were unvaccinated, but was happening from eating indoors, with others in a close area. Now, if everyone is fully vaccinated, that changes things. But I would say safest advice always right now is to eat outdoors if you can. If you're having a meal with family, I would recommend having it outdoors. Even if you're in, I just came back from Houston to visit my family, hadn't seen them in a long time. But I was like, you know what, if we're going to go out to eat, I know it's 90 degrees outside, but we're going to have to sit outside on a patio because it's just not smart at the moment. Just like we explained, the entire United States is a hot spot at the moment. And so if you can eat outdoors, that would be best. If you're in kind of a tough work schedule and you got to eat indoors, I would recommend definitely being around others that are vaccinated, and if possible, trying to have a space that's your own to eat. That's probably the safest thing to do at the moment.
What other, go ahead.
Yeah, no, I just echo that. I mean, you give me PTSD thinking about all the issues that we've had in the healthcare setting with break rooms and shared eating. I mean, people got to eat, but clearly, based on our experience, that was a high risk point, and I think that was a very similar experience that others throughout the country we're having. So I share your opinion. We're not eating indoors. In a mixed household as well, vaccinated and unvaccinated people, in such a high transmission, it's hard for me to do indoor dining, and I haven't done it.
Second to last kind of combination of questions. How big of an issue were heart problems in young adults 12 to 18 who received the vaccine? Is this being looked at in terms of approval for children as well? The timeline for the approval for children?
Yeah, I can start there. So the issue being brought is the question of a very low frequency event of myocarditis or inflammation of the heart tissue seen among younger, more men, more boys than girls who had after mRNA vaccines. I think the emphasis on this issue showcases the robust safety mechanisms that we have in this country through VAERS, the reporting system for adverse events through vaccines, to find such extremely rare events. So it was a similar story with the J&J vaccine and the blood clotting issue that, there are signals of this very low frequency event. And the fact that we found them, I think, is just a testament to how scrutinized the data is. So I think in those cases where myocarditis has been seen, thankfully they've been for the most part benign and self-resolving, has not led to significant morbidity or long-term effect for those people. And I think on the flip side, we know that COVID itself, it actually can not infrequently cause myocarditis. And so when you look at sort of the risk balance and sort of the risks of COVID and all its sequelae, long-term COVID myocarditis, and then sort of the risks of the vaccine and the very, very low frequency of those safety events with otherwise the robust sort of safety profile of the vaccinations, I think that very clearly, the benefit of vaccination outweighs the minimal risk.
I totally agree with that. And I would just point this questioner to a really interesting study that came out by Miguel Hernan from the Harvard School of Public Health this last week. And Dr. Hernan, it has an interesting kind of method of epidemiology that he studies, where it's kind of like he studies in time what would happen if you did this versus this. And he looked at people who, got the vaccine and a group of people who did not get the vaccine. And when you compare the complications of things like myocarditis, or just all of the things that can happen, blood clots, all of the things that can happen if you were to get COVID, if you were vaccinated or not. The evidence, we thought that, and this paper kind of proves that the evidence just is so heavy towards vaccination, and remembering that any virus can give you myocarditis. And so, unfortunately, that risk is always going to be there, and probably is much more heavy with the virus itself rather than the vaccine. So the evidence seems to show that the safest way to proceed would be to get vaccinated.
Wonderful. I think our other questions look towards the future. As we head to the fall, do we foresee more COVID cases? If you look even further, 3-6 months, I think another participant asked for 10 years. So a lot of complex questions combined and offered to you.
I will just take that because I was looking at some of the epi data this morning, and it's not reassuring that unfortunately the cases continue to rise. We at this point look like we are going to have more cases in August of positive infections and deaths than we had in June and July combined, which is really, really, frustrating and sad. And we worry in the infectious disease community that winter months are much harder in terms of respiratory viruses. People are indoors, there's less ventilation, you can't get outdoors. It's very hard to convince my colleagues to, step outside for lunch when it's snowing outside and it's 0 degrees, right? And so I think that we are very worried about the winter months coming and what's happening. The best way to fight this would be to be increasing vaccinations. And that's just in the US. Of course, we're also thinking internationally about what's going on. And I really think that vaccines are going to be the way. And so if there's one takeaway, I would say anyone listening to this, if there's someone in your family that's still, unconvinced, please, try to take some of this information back to them. And I'm going to share my screen because I know we only have a few minutes left. And I'm going to show you this website here. So this is the COVID-19 Real-Time Learning Network. I know we got to a number of questions today, but I'm sure you all have many, many more questions. And I think this is really a great resource for you to come with those questions. So here's the website. Even if you just Google, COVID Real-Time Learning Network, it will come up. We have some frequently asked questions. And so, that's a really nice resource, and it might get to a lot of the things that you're wondering about in terms of boosters and timing. And if you want to look at the evidence behind masking and social distancing and back to school, we have a section on all of those. And so again, I think this is a really nice resource that you can share with others if they have questions in your family.
Thank you, Dr. Patel. Dr. Suchindran, if you had...
Yeah, I just wanted to add on to that. Dr. Patel has already sort of challenged all of you, on an individual basis to, talk to anyone and everyone about the importance of vaccination. I also want to acknowledge that, this is a very, powerful and well-connected alumni group for MIT. And so, I think that, with your, the power of your network, if there's anything that you can do to even move beyond the individuals, but to really look at, what can you do as donors, as a powerful alumni network to support the delivery of vaccines to low and middle income countries, particularly with your connections to South Asia, really, kind of helping the vaccine delivery there. Please, use your effort, use your time, use your money. It'll all be of benefit.
Thank you. On that note, this has been an exciting session, but all good things must come to an end. Before closing, I wish to thank our excellent speakers, as well as the MIT Alumni Association. On behalf of MITSAAA and myself, thank you all for participating in the webinar and making it a success. Hope to see you all in person at another MITSAAA event very soon. Thank you and have a wonderful day.